Okay, good morning, everyone. It is truly an honor to introduce my one of my favorite, one of my neurologists, Dr. Danny Benmoshe. I want to give you just a little backstory on how we became acquainted. Now, last year, I was very exhausted, and then I was coming home, and Jeannie noticed I couldn't get the seatbelt on. So anyway, and I was having a headache doctor. And so when we went to the headache doctor and we told her what was going on, she said, I want you to get a full neurological workup. So I said, okay. And she said, wonderful for you. It took her forever to find Dr. Benmoshe's card, but she found it. And so I called him. They were so kind. They took me within like 2 weeks. But the main thing that I was so impressed with is God. He spent 2 hours, 2 hours with Jeannie and I, and he gave me a very thorough examination. So Kim will put his website in chat. You can Google him. I can't read his about him because that will take the whole session. But he has his Doctor of Medicine from Albert Einstein College of Medicine in New York, his Bachelor of Science, Neurosciences from UCLA, English, Spanish, Hebrew, and we are just so grateful and thankful that he would take time out of his busy schedule to be with little acts. I always say little acts, but a big God. So I turn it and thank you again.
Thank you, Sharon. Thank you so much for the introduction. I really appreciate it. Thanks for having me. As Sharon said, I'm a neurologist. I'm in West LA. I finished my training in 2010 from Harvard UCLA and started my own private practice about 10 years ago. Yeah, you guys can Google me if you ever want to come see me for any reason or need to bring anybody, your loved ones, etc. And yeah, I'm happy to be here. I'll go ahead and share my screen and we'll do a little introduction and my my goal today was to share some slides that I've presented before for the Alzheimer's Greater Los Angeles in the past about dementia and Alzheimer's and different things, and feel free to ask me some questions as well. Okay, so let me go ahead and can I share my, oh no. Are you able to let me share my screen?
Yes, yes. 1 second.
Sure. Okay. All right. I see it now. Okay. So, I'll go ahead and, okay. Are you guys able to see it? My
Yes.
screen?
Yes.
Yeah,
Okay, great. Okay, let me just make it a slideshow here. Okay, no, wait, is that slideshow? Sorry, I haven't done this in a while, so forgive me.
Nope.
Uh,
Right at the
okay, there he is. Okay, all right. So, like I said, I'm going to try to give you an overview of dementias and what dementia is and what does that mean and how to try to be proactive about it as a patient. And we'll talk a little bit. These slides, unfortunately, are a little bit older. I haven't really updated them, but they're newer treatments that I can speak about towards the end as well. And of course, if you guys have any questions, just feel free to ask me. So let's talk about dementia. So what is dementia, right? So dementia is the overall term that describes a disorder characterized by, excuse me, decline in cognition. So anything that affects processing and acquiring knowledge compared to what a person's prior level of functioning was. So in order to be diagnosed with dementia, you have to have one of the following domains or areas affected enough to impair a person's daily activities. So, trouble remembering events, repeating questions over and over again, word finding difficulty, being able to figure out how to cope with unexpected events or new situations, complex attention. An example is a person having problem balancing their checkbook where they didn't have a problem in the past. Um, Motor perceptual function, like getting lost in familiar places, and especially with driving. Social cognition, so any changes in behavior, aggressiveness, isolation. A person, for example, who has never been a depressed or anxious person who suddenly becomes one, that could be a sign of a dementia as well. Um, and it doesn't have to be just a memory thing. That used to be the thing, the category in the past or prior criteria. You had to have some form of a memory, like a short-term memory. But nowadays, as long as one of those six categories that I mentioned is affected, you can start thinking that the person might have a disorder that needs to be looked at. So, um, so just a little bit of numbers and statistics. So, dementia affects worldwide 35.6 million people. This is per 2010. So these are a little bit old statistics. In the US back in 2012, about 5.2 million people were thought to have Alzheimer's type dementia. And the number is about to be about 7 million, or should be around 7 million now, especially because people now are living longer. We have better medicine to keep people's life or life expectancy longer. But unfortunately, we're not as advanced in promoting brain wellness or affecting brain wellness, but we're working on it as far as the science community, scientific community, the neurological community. I think in the very next decade, or this even decade, we might be able to even find a cure for something like Alzheimer's and perhaps other what we call neurodegenerative disorders, as there's more and more research that's being spent time and money on finding a cure. So, as I mentioned, dementia is the umbrella term that it is implying that a person has some form of a cognitive impairment. Again, it could be memory, it could be social, it could be executive function, it could be visual spatial. And then there's the types of dementia or the reasons for a person to have dementia. And bottom line is each one of these disorders that I'm going to mention have their own different pathologies, the reasons why it starts, how it starts in the brain tissue. We're not going to go into that today, but I just wanted to kind of bring into your attention because people always confuse dementia with Alzheimer's. And the first thing is dementia is the overall umbrella again. Alzheimer's is a type of dementia. It's the most common type of dementia, as you see here in this slide. It's up to 75% of patients are thought to have Alzheimer's dementia. And then there's the other subtypes that are not necessarily Alzheimer's. So just because somebody has memory problem doesn't mean it's Alzheimer's. It could be a vascular dementia because, for example, they're not taking care of their vascular risk factors, right? Blood pressure, cholesterol, diabetes, other things. There's Lewy body dementia, where it's kind of like a cross between an Alzheimer's and a Parkinson's, where they kind of have features of both. And then there's frontotemporal dementia. You probably heard of now in the news Bruce Willis. He's known to have frontotemporal dementia. It's not as common. Um, and then there's like less common types of dementia, like the progressive supranuclear palsy. The Parkinson's has its own dementia, corticobasal degeneration, Huntington's, CJD. So, the other thing to really kind of also understand is that a lot of times we don't know exactly what a person's reason for dementia is. We think it's could be this type or that type, but there's unfortunately no one way to really know. We do tests to rule in and rule out the types of dementia. And most times we do believe that people can have a combinations. They can have an Alzheimer's and they can have a vascular, you know. And again, the way you diagnose them officially is by doing a brain biopsy and looking at a slide of a person's tissue, right, under the microscope. But nobody's going to do that because that doesn't make sense because it's too much risk and it doesn't really make a difference in the management at the end of the day. So luckily nowadays we have newer technologies to help us. Figure out what kind of dementia. But again, it's not the gold standard there. It's not like one test. It's multiple things. It's you guys coming to see somebody like me, a neurologist, me doing the exam, me sending the person to do testing like blood tests, imaging tests like MRIs, PET scans, maybe some spinal tap, whatever is required to kind of help the diagnosis. And then there's also the types that are reversible. Sometimes a person comes in and they may not have an Alzheimer's type dementia, but they have a reason to have a dementia because of something they're doing in their lives or something they've been doing or been exposed to. For example, uh, chronic consumption of alcohol in big dosage can, of course, cause brain cell death and therefore dementia. Chronic traumatic encephalopathy, you may heard that term for, the footballers, repeated head traumas, football and boxing and even soccer. Certain medications can mimic dementia. People who are taking medications like Benadryl, Ativan, Xanax that can actually affect your short-term memory and your hippocampus. Um, we also check in when we do a workup for infections, things like HIV, Lyme disease, syphilis, because in the long term they can affect the brain. And also we as neurologists and doctors, we always have to check for other metabolic issues like changes in thyroid, vitamin B12, sometimes vitamin B1, and a couple other metabolic testing that we do to make sure that we're looking at all the factors. There's a stage that is called mild cognitive impairment, and that's the stage that we sometimes diagnose a person with before they're officially meet the criteria for dementia. Mild cognitive impairment is sort of in the spectrum, if you will. It's a transition between memory problems from normal aging and dementia. It's sort of like when is really themselves are feeling that there's something off about their memory. They know that they can't do their task as well as they could. Maybe they have to ask a person now for help, but they can still do their day-to-day activity. They could still work. It's just a lot harder for them to do what they were able to do in the past. And some patients do eventually progress to overall dementia, like Alzheimer's or the other types, but not all the patients do. And unfortunately, we don't exactly know who does, who doesn't. We have ways to do, like I said, other tests like blood tests, imaging, etc., to try to risk stratify to see who's going to progress to the next stage. Then there's also risk factors that we, of course, always try to hit with a patient to talk about things that are modifiable, right? So I mentioned the vascular stuff, right? So a lot of patients, especially as they get older, have risk factors like the typical triad, right? The blood pressure, cholesterol, and diabetes. So hypertension is now considered the most modifiable risk factor. So again, when you get older, it's very important that you follow up with your primary care doctor and you try to control these risk factors as much as possible because just by having these risk factors, vascular risk factors, you can cause yourself to have a dementia. uh, other things like obesity, things that maybe are a little bit harder to do as you get older, but educational level, if you come from a lower educational background, it's the theory is that you may not have the brain reserve. You know, people who challenge themselves and try to learn even as they are in their older life, uh, like they take classes, course classes, just to learn new skills. It's just brain retraining, learning new things. That's a modifiable risk factor. I also mentioned already diabetes, having depression in late life by itself can accelerate or cause a person to develop Alzheimer's or other types of dementia. not being physically active, smoking, being socially isolated is a big thing. And also nowadays, I really push people to get their hearing tested because if you are having a hearing issue and you're not taking care of it, guess what? There's more and more data that shows that you might end up having dementia because it sort of adds to that social isolation. You need uh, stimulation. And so let's say if you think about it, if a person is not um, they're isolated, they're not hearing, let's say even if they're in a group setting, they're not hearing what their peers are saying, they're basically being isolated. And you're not stimulating the brain. So you need to make sure that the brain is always getting sensory input, the vision, the hearing, all those kind of things. And of course, there's things that unfortunately we can't do anything about, right? Age, genetics, history of strokes, history of head traumas. Okay, so when a person comes to see me as a neurologist, these are the things that I usually do on the first visit, right? So I always try to get the patient in the room, but also one of their family members. It's very important that I get collateral information because the patient may think that they're not having any issues, or may think that their issues are not as bad, but maybe the family members are seeing it differently. So it's very important for me as a neurologist to always have a family member present, if not in person, at least maybe on the phone, so I can ask them questions as well. Of course, I always try to do a good job as a neurologist to go through all the person's medications because, as I mentioned, certain medications can actually accelerate or cause a person to have a memory issue without them unfortunately knowing that that's the case. I do certain types of screening exams. After I do my general neuro exam, I do a mini mental status exam, a MOCA, and then there's other ones that some other doctors might do, like a clinical dementia rating, a mini cog, depending on the doctor. I mentioned I do my physical and neurological exam, and then I would send the patient to do my workup, including blood tests, like I said, nowadays this is an unupdated slide, but luckily we have newer technology and the serum biomarkers, and we can even now do testing for serum biomarkers. Those things that you see on where it says lumbar puncture. A lot of this stuff now we could do just by blood test, which is a big plus, right? Because I usually try not to send my patient to do something invasive like a spinal tap. That's what the lumbar puncture is. Um, anyways. Then there's other tests that I do. We do an MRI, preferable because it gives us more idea of the actual structure of the brain, like looking at the brain volume, looking for extent of vascular issues, right? If a person, for example, has extensive what we call white matter disease, which really implies that they have a lot of plaques in their arteries, just like you can have in your heart artery plaques you can have in the brain. And the more you have that in the brain, the more likely you might have memory problems down the line, which is not an Alzheimer's type dementia. That goes more with a vascular type dementia. And nowadays we do even further other functional tests. There's an FDG PET, and now there's amyloid PET, which is my go-to first line, at least to rule out Alzheimer's type dementia. The good news is since 2023, amyloid PET scan has now been approved by Medicare, so a lot of doctors now can order it. The patient can get it done, and if they have Medicare, preferable Medicare as a primary and supplement like a ARP or a Blue Cross, it's easier to get done. You can still get it done even if you have Medicare Advantage and the other ones, but the bottom line is Medicare now allows doctors to do an amyloid PET scan, which kind of helps us further differentiate the reason for the person's memory issues to see if it's an Alzheimer's type dementia or not. Um, and then one thing about the amyloid PET scan, another reason to do an amyloid PET scan is, and I'll talk about one of the drugs or the drugs that we have now. We have new drugs now that can take out the amyloid beta, which is the main protein that is affected or that basically is the starter of an Alzheimer's. And with confirming amyloid beta in the brain, if we confirm a person has amyloid beta plaques by doing an amyloid PET scan, and if they're qualified based on criteria, they may be eligible for infusions of certain drugs that can take out the amyloid beta plaques. Now, that being said, I have to sort of also caveat that these infusions are not cures, unfortunately. Like I said, we don't have cures, but they do slow down the progression of the disease. So, one of the things I sometimes do for some patients, if, for example, I'm not sure that what I'm seeing in front of me is truly a memory issue because there's things such as what we call pseudodementia, right? A person who is severely depressed or may have undiagnosed ADD or ADHD, and now is telling me that they can't do certain things. And let's say per my testing, they're not really meeting full criteria. I might send him to do a neuropsychological testing. It's basically a 3 to 4 hour pen and paper test that is done by a specialized psychologist. These are psychologists who did extra training to do memory testing on patients. And then based on their battery of tests, they can figure out if there's truly is a memory problem. If so, how bad is it? Or is it something completely different? Is it really a sign of a really severe depression or anxiety that's causing a person to have attention issues, etc., that looks like a memory problem? So that's also very important to know about. So let's talk about Alzheimer's disease itself, the main type of dementia out there. I'm just going to give you a little bit of history. The reason it's called Alzheimer's is because it's named after a German psychiatrist that basically was able to categorize a patient back in Germany in 1901. And he was able to study that same patient's brain and was able to find the pathology of it, the amyloid beta plaques, the tau tangles, and he was able to basically say that there is a specific type of dementia called Alzheimer's, or he named it after himself, or they named it after him basically. It affects different age groups at different rates. Basically, the theory is that 50% of people over age of 85 or may already have some form of Alzheimer's dementia or might be prone to it. It does affect women more than men. We don't really know why, but one theory is that women also live longer, and so the longer you live, the more likely you're going to get this disorder. And it, of course, causes a lot of disease burden, socially, financially, etc., for the US and the world in general. I mentioned this a little bit, but if you can see here on the this side, the slide, this is what a normal brain looks like. If you imagine these are normal neurons or brain cells, they're supposed to look like this when you look at them under a slide. But a person who has true Alzheimer's, if you were to do a biopsy or even post-mortem, let's say after they pass away, and you look at their brain, you're expected to see two main proteins, the amyloid beta plaque, which is what I mentioned the amyloid PET scan checks for, and the neurofibrillary tangles. These are other proteins that get accumulated inside the brain cells, and both of them eventually cause the brain cells to die off. And that's really the reason why people develop memory issues because you have loss of brain cells or brain cells dying off because of these two main proteins that start accumulating. So what kind of things happen in a person who starts having Alzheimer's? And we do know, by the way, that this amyloid plaque now starts getting deposited in the brain at least 15 to 20 years even before a person even starts getting memory issues. So nowadays they are studying these drugs that I mentioned, these infusions, to see if somebody has these amyloid plaques, but they're preclinical, meaning they're not symptomatic if it will make a difference in the long term compared to patients who don't get these infusions and get these plaques deposited. So, a common symptom that might occur in the very, very early stages of somebody with Alzheimer's type dementia is, as I mentioned, short-term memory, right? Difficulty with the day-to-day stuff. They forget where they put stuff. They might even start getting issues getting lost, driving to unfamiliar places. Difficulty doing financial tasks, right? Balancing checkbooks, paying bills on time. Later on, as the disease progresses and you get more buildup of these amyloid plaques and the tau tangles in different parts of the brain, you get more other areas of cognition being affected. So language gets affected where a person can't recall certain words. Then you might start getting behavioral issues. Some people get more irritable or aggressive. maybe even violent. It's sometimes. And then there's that term sundowning, as you may know of, a person who, when their disease state gets to a certain stage, when it gets dark, right, sundowning, they get more aggressive or more confused. And in the very advanced stages, unfortunately, that's when a person unfortunately becomes bedridden because they can't do things for themselves at all, and they may even forget to feed themselves or feel hunger, and that's when a person can pass away indirectly from something like Alzheimer's, right? Because bedridden means that they're in bed and they can develop, God forbid, bed sores, and that's how people start having issues, complications, going to the hospitals, etc. Other things that patients might actually have with certain dementias is loss of smell or taste. Patients start maybe even developing sleep issues when they didn't have sleep issues before. And in extreme cases, especially very advanced dementia, some patients with Alzheimer's especially can develop seizures. So that's one of the things I do in my office. I do an EEG to check for any possibility that person might be having seizures, even subclinically, not the whole body shaking, but, just spacing out, that could be a sign of a seizure sometimes. Um, so, how does the disease change? So everybody, the way it changes for people, people always ask me when they come see me, or the loved one asks me, well, what are we expecting? Unfortunately, there's no really one way to really know how a person's going to progress. We don't have that technology or really a good tool, but certain things we do know based on statistics that if you were diagnosed at the later age, like in your late 70s or 80s, you're more likely to decline slower than somebody who starts developing memory issues in a younger age, let's say in the mid 50s or 60s even. Average average age life expectancy after diagnosis between 3 to 11 years. Again, these are statistics. It all depends on multiple factors, how well you are, aside from the memory issues, as far as your other risk factors, like I said, diabetes, cholesterol, that kind of stuff. And then I mentioned the cause of death due to terminal stages usually are because of things like dehydration, malnutrition, infection, bed ulcers, like for example, or developing pneumonia from not being mobile or being bedridden. Um, so the main two drugs that are considered treatment, but they're symptomatic treatment, right? These are the medications that we give patients to help with their day-to-day remembering things, to help remember things better. So the one that you might all know of, donepezil or Aricept, usually up to 10 milligrams. Some people I see take up to 23 milligrams. I like galantamine, the other drug here listed, because it comes in an extended release. There's a patch called Exelon, or it also comes in oral form. And then there's another medication called memantine or Namenda, which is really indicated for people with more advanced disease, moderate to severe Alzheimer's type dementia. There's those two main drugs. And I mentioned the drugs that are infusions. This is again outdated. Back in 2021, a drug came out called aducanumab or Aduhelm, which was the first in its class to take out the beta amyloid that I mentioned out of the brain. I used to actually infuse it in my office, and for different reasons, they decided to discontinue this drug. Now there are two new drugs that are out there in the market. Again, I apologize for not updating slides, but the one called Leqembi or lecanemab, and the other one's called Kisunla or donanemab from two different pharmaceutical companies. They're basically infusions, basically given IV once a month or once every 2 weeks, depending on the drug. And you're doing it for about 36 infusions or a year and a half worth of infusion. And again, it's supposed to help take out that amyloid plaques that we saw in the amyloid beta PET scan. And it's supposed to help slow down the disease. It's not a cure. Patients still progress. But the theory is that if you get this drug to the right patient, their disease states basically stays more mild longer than if they were not to start these drugs. People always ask me about supplements. What else can they do or take? Anything that is considered to be antioxidant is considered to be good. One thing I would say though, I wouldn't go too crazy on supplements because there is such a thing as too much supplements. Just because they're supplements doesn't mean that they don't have their own risks of side effects and other complications and interaction with the drugs. So you always have to be careful. You don't want to go too crazy on drugs. But we know that certain drugs are relatively safe, like a vitamin E at a certain dose, B complex, omega 3s, garlic extract, anything that's considered antioxidant. Um, as far as diets, there's this thing called the Mind diet, which is basically a version of the Mediterranean diet. And this is like the healthy lifestyle diet that you probably heard from your primary care doctor. These are basically the diets that are low in processed food, low in fat or red meat or high sugars. They're more in the vegetable, the salads, berries, antioxidant type foods, more poultry or fish, and then again, avoiding the bad stuff. Um, and of course, exercise is very important, even for patients in different stages of dementia, because we know that it improves mood, it improves sleep, reduces issues of constipation from not being mobile, it helps maintain motor skills, improve behavior, and just, being in a group setting like what you guys are doing, like it's a good thing, especially exercising together. It's very beneficial for patients with certain dementias in general. Uh, Different exercise types are also good, like anything that accelerates your heart rate a bit. Of course, if that's okay with your primary care doctor and you don't have any restrictions. So basic things like walking is probably okay, right? Cycling, treadmill, Tai Chi is great. Dancing, gardening, also very good for the mind and just being outdoors. Um, and this is sort of, again, these are trials that I used to be on, so I'm not going to go through that. And that's pretty much it. Thank you.
Thank you, Dr.
Okay,
Benmoshe. And
sure.
I can hear good. Does anyone have questions for, Doctor? Okay, we have in the
Hi,
room.
this is Adrian. I have a
I'll
question.
put it one at a time. Please, raise your hand online and I'll just call out the people so we don't all talk at one time. I think we have the first person here in the room.
Oh, hi, I'm Sharon Pickford. So my question is, have you seen an increase in dementia with the elderly after the pandemic? Because I'm in the health field and I have seen a humongous increase in dementia with the elderly, and I've been seeing clients since like 2004, and I've noticed that more and more of my caseload has been dementia, particularly women and particularly African American women.
Uh-huh.
Uh, and do you think that there is some kind of connection between that? Give you too many questions, and the vaccine, which I understand was affected the vascular system.
Yeah. Well, it's hard to say exactly, because a lot of other things changed during COVID, right? So a lot of social networks sort of shuttered and just recently re-expanded. So, one might say that maybe it's not necessarily the disease itself or even the vaccines, but rather the fact that people are not as coming together as much and doing as much, and people may be feeling that they have no choice to be isolated. And there's so many different moving parts in a sense, because these drugs are coming out, there's been more and more of a focus to find people at the very early stages now. Because in the past, for example, even as neurologists, we never really liked to do a lot of dementia work because it was just it's a difficult disease, right? It's for more so for the family than it is for the patient at times, right? And for neurologists, it's frustrating because you see a patient, they're getting worse in front of you, you can't do anything. Family's getting more and more frustrated with you, and at the end of the day, it's hard. But nowadays, because we have these new drugs and there's a better push and there's a lot more education, if I don't know if you've seen more ads for talk to your doctor about if you're having these and these symptoms. You want to do something about it sooner rather than later. You don't want to do um, you don't want to wait too long. So it's hard to say. Again, going back to the COVID question, I can't say that there's a direct association. There's a potentially an association, but I can't say that COVID is the main culprit here because there's again so many different factors that could have caused a person to start being more isolated or maybe not see their doctor as regular for their checkups, and maybe their other risk factors got worse, for example, those kind of things.
Thank you. Adrian, I see your hand.
Yeah, so a question on cures. I've heard people talk about, down the line we'll have those, but I know also that with brain atrophy, you can't, regrow brain tissue. So when you think about those cures down the line, is it really about early diagnosis or preclinical diagnosis, the ability to remove plaques and things like that, that might lead to the possibility for cures?
Yeah, I think that at this point in time, until they know how to stop a cell from dying, like a brain cell from dying, the focus is going to be on early Alzheimer's or early detection and prevention, and maybe even prophylactically if they see the current trials that are doing right now. Excuse me, a little bit under the weather. The trials they're doing now is like, as I mentioned, are people that are amyloid beta positive, but they are not showing any signs of memory issues. So they're giving these infusions to these patients and then comparing to placebo. People who are not getting those drugs, or again, it's supposed to be blinded, so nobody really knows who's getting what. And it will be interesting to see, at least for the short term, next maybe couple of years, whether this is the drug or these are the drugs to give until they finally figure out a drug, some form of a drug that can actually stop a cell from dying or maybe even regenerating cells, you know? So until we have that, I don't think that there is any specific compound. I mean, they're studying a lot of things. You've probably seen a lot of stuff, especially in mice or mouse models. Unfortunately, one thing to say about mouse, I'm going to go on a tangent, but a lot of things you see in mice models don't always translate to humans, unfortunately, right? But we could at least try to kind of make educated guesses, and there's a lot of focus on prevention with supplements like creatine, for example, is a big thing now. A lot of my patients are asking about that. Things like even GLP-1s like Ozempic and tirzepatide are thought to be potentially anti-inflammatory in the brain, right? So anything that reduces inflammation in the brain, so theoretically also will help stave off cell death in your brain. So that's a lot of focus right there. But I think right now we're just focusing on early detection as the main thing, just because we don't know the mechanism yet of how to stop the cells from dying or how to help them stop themselves from dying or be more resilient to any proteins that are accumulating in the brain, basically.
Thank you.
Sure. Good question.
Go back and forth, I see.
Doctor, just going back on those two drugs, the new ones, when neurologist in May, I know you mentioned one, they said as well, it's pricey Medicare. And I don't know if that was one you was talking about, one was in, I don't think that was infusion, but the main thing, the side effects, that's what I want to go over.
Oh, okay.
One, like a 25% chance of brain aneurysm in the
Yeah.
brain.
So,
And,
yeah. So these drugs, yes, these are good. The good thing you pointed out. So there are risks with these new drugs. The risks are microbleeds and micro swelling in the brain in the first 6 months of the infusions. That's why we have to do serial MRIs. So like a patient who goes through these infusions, depending on which drug, they have a sort of a protocol when they have to get re-imaged by an MRI. So a person has to be able to do an MRI periodically. Now, even if they do get those microbleeds and micro swelling, 99% of the time, these are benign type of finds, meaning a person, if they were to have any symptoms or they're mild symptoms, I myself infuse these drugs in my office, at least one of the drugs, I should say. And I had a couple of cases of patients getting these microbleeds and micro swelling. At most, one patient had a good amount of headache, that all we had to do was stop the infusions, wait a good couple of months. Headaches went away. We treated symptomatically, and they basically were able to decide whether they wanted to go back on the infusion or not. They opted not to for different reasons. But I do have other patients who did develop the microbleeds, microswelling. They were completely asymptomatic. They didn't have any symptoms whatsoever. The only reason we found that they had is because we had to do these repeated MRIs. And if you look at the studies for these drugs, the main trials that they study these drugs with, majority of patients who had these bleeds and swellings were not symptomatic, but they saw them because they had to do these MRIs. So that being said, I also am very selective on who gets these type of drugs. A person has to be very overall healthy from a cardiovascular standpoint, meaning they're allowed to have things like blood pressure, cholesterol, diabetes, but they have to be very controlled or optimally controlled by their primary care doctor. Because God forbid if they, for example, have to start blood thinners or got to go to the ER to get a clot busting medication if they have a acute stroke, right? Like they give these TPAs or clot buster type meds, they can potentially, God forbid, die from a brain bleed. So, for the most part, I would say they're safe, but they do carry risks. Again, I think that the benefit outweigh the risk, in my opinion, but it also depends on the patient. If they are not well controlled with their blood pressure, cholesterol, diabetes, they should not be getting these drugs until they're controlled.
One you said was now Medicare now will discuss one. They say, oh, it's too pricey. Medicare won't cover it. You have to pay out of pocket.
Uh, the first drug that I mentioned in my slide, the Aduhelm, was the one that Medicare was not covering. But in 2023, the first drug that was covered was lecanemab or Leqembi. That's the drug by Eisai. That's the one I do in my own office, and I also send patients to infusion centers if they live too far away. And that's been covered since 2023, beginning of 2023, and so is the other drug. So basically, as long as you have a Medicare plan, you should be covered. That being said, a caveat is that if you have a Medicare Advantage, it's a lot harder to get the drug. It's not impossible, but you have to go a lot more through a lot more hoops because it's an Advantage plan and it's a little bit too nitty-gritty details here. But there's more of the prior authorization and blah 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 blah. I would say if you are very interested in these drugs, your best bet, that's what I tell all my patients, is to go on a traditional Medicare with a secondary, like an ARP or Blue Cross Blue Shield or something, because that way it will cover the infusions, the doctor visits, the MRIs, the blood tests, all that stuff basically.
Tea Park.
Is there a way to manage the sundowning?
Yeah, it's a challenging thing. I sometimes myself like scratch my head, want to pull my hair out because it could be difficult, because some patients are just whatever you give them, they either have a reaction or they can't tolerate, or they may have an issue where the drug that you might want to give them is going to interact with their other drugs. The best type of way to do it is through behavioral type of modification. If you go on the UCLA Memory Clinic website, I forgot the link, might be able to find it and share with you guys, but that's one that I actually recommend for patients and their loved ones. It's available to the public. You don't have to be part of the UCLA system. And they have actually really good tutorials and like videos for caregivers on how to deal with patients who have aggression, and because most times you want to not have to give something to the patient. Unfortunately, a lot of these drugs that we do give do carry a black box warning with cardiovascular events, right? They did see that people in general, elderly patients with dementia who get the antipsychotics or even antidepressants are slightly more at risk for developing, God forbid, heart attack, strokes than people who don't get it. So the first line is to try to modify the behavior, modify the environment, with the patient, make sure that they have a good schedule when it comes to sleep, always push them to go to bed at the same time, not letting them do bad habits like going on, watching TV before going to bed, and that's going to keep them up, and those kind of things. They have to be in a good environment. And then on top of that, if they're still not sleeping, then I would throw in or I'd recommend a as needed antipsychotics like Seroquel or quetiapine that they can use for sleep and sometimes even during the daytime for agitation. There's other drugs out there, a lot of off-label things like Depakote. There's newer atypical antipsychotics like Rexulti. There's a lot of things out there. There's newer drugs now that are trying to be marketed for that purpose. But there's no one drug. You sometimes I do a lot of times have to go through a trial of different drugs and a lot of counseling with the patient's family and or their caregivers to explain what needs to be done.
Dr. Lauren put a link in the chat, our caregiver training videos regarding sundowning for everyone online. And I can share that out, in email as well. That question just came from online or in the room? Where did it just come from? Online. Okay, in the room, Brenda.
So, question, I know you said that there are tests that are now being done through blood analysis to help diagnose. Do you think that at some point in the near future that be incorporated into as opposed, waiting down the road? Because if it's being done through blood analysis, why can't it be incorporated now? Not all of them, but maybe some of them, so that people can kind of get an indication that maybe they need to change their lifestyle or something.
Yeah, that's a good question. The thing is that there's a time and reason to do it. As far as I'm just reading an article through one of my medical journals that a lot of companies now allow patients to do, excuse me, order their own blood tests, without even the doctors asking for it, which could be a good thing, but it doesn't have to be or it may not be because if you don't really have any signs of memory issues, then do you really want to know if you are at risk for developing a disease that doesn't have a cure? I think that, it could go both ways. It's a very kind of divisive type of question because some people say, yes, I want to know so I can prepare and I know what to do and I can, make my affairs and I can counsel my thing. But some people say, I don't want to live my life worrying about it, that I'm going to get there and I'm going to be depressed and, that's going to cause its own issue. So I think that the short answer is that nowadays it should only be ordered by a physician if they see or they have a high clinical suspicion that their patient in front of them is having true memory issues. That's when it's really a good idea to do it, and that's what I've seen so far. I mean, some doctors now kind of are just ordering on everybody. I don't know if it's the right way to do it. I think that it should be done in a setting of a memory clinic or like a neurologist or a geriatrician, somebody who knows what the significance of these labs are and what they mean. And one thing to also note is that unfortunately the blood tests, they're not FDA cleared except for one of them that just recently got cleared by the FDA by this was this one company Fujibera. And that's the only test that's been FDA cleared. And the reason that's the only cleared is because they were able to excuse me, show that there is a good reliability on the results of the test. The other tests, there's so many different companies out there. There's LabCorp, there's Quest, there's C2N, there's I don't know every other blood test. There's so many blood test companies out there. How do you standardize it? So for the time being, I think that you should do these tests in the clinical setting, right? If it's going to help the doctor to help the patient, then I think yes, by all means. Especially if you want to make sure that you're finding it early. And that's one of the reasons why they've been pushing for these drugs, for these tests, because it helps the primary care doctor further screen a patient that they're concerned that has a memory issue. And so I think it is a good thing that we have it, but I don't think that everybody and their mother should get it. You know what I'm saying? It's just be for people who really are at that category of patients who are at risk.
But that, does that include menopausal women who are having memory challenges because they're going through menopause?
So that goes back to like going to see a specialist like a neurologist that can really help distinguish whether the menopause is the really cause of the memory or is it actually an underlying issue like an Alzheimer's dementia. You know, normally a woman in her 50s, it's not common for a woman in her 50s to start getting dementia that early unless they have a strong family history. That's a different story. You know, just by being menopausal, you know, you can have hormonal changes and lack of sleep and other issues, and that just by itself could cause a person to have memory issues. So just because you start being forgetful doesn't mean, oh my God, I have Alzheimer's. Of course, you know, you could consider that's a possibility, but I wouldn't like panic and start asking for all the tests. I think that you got to go see the right doctor for it. I'm not saying you guys should all come see me, but you should see a doctor that is experienced in treating patients of a certain age. So, you know, I do like patients to see obviously a geriatrician if they can, because they are primary care doctors who are more involved in elderly patients than just internal medicine that sees a spectrum of different ages because they should be able to also do the same things that a neurologist can. Or worst comes to worst, you know, or if you want to, then you can always ask your primary care doctor to refer you to a neurologist, and hopefully they would know what to do.
Thank you. Barbara, I see your hand.
Yes, yesterday my cousin called me and she's 67. She has type 2 diabetes and she was just diagnosed with emphysema and she says she has brain plaques
Hmm.
in the front part of her brain. So is that indicative of Alzheimer's or is it just something else?
So plaques can mean different things. So brain plaques, do you know if it was based on an MRI or a PET scan?
MRI, and then she's having a secondary one.
Okay. So brain plaques, when it comes from an MRI test, that implies, so plaques mean different things. So plaques are basically are just like gunk, if you will, right? Different things can cause gunk in the body, right? If it's an MRI and they're calling it plaques, that is implying that the arteries in the brain are having like cholesterol and calcium plaques or gunks, cholesterol, calcium, and maybe some platelets. And that's the plaques that they're talking about with an MRI. And that just implies that she might not be controlled or wasn't really controlled at one point with her diabetes. Do you know how good or bad her A1C is or what her levels are?
She said her sugar is normal. She was diagnosed with diabetes about 5 years ago, and she
Mhm.
also has, controlled cholesterol and controlled high blood pressure.
Okay.
And my mother had dementia, her aunt, and I think my aunt, her mom,
Mhm.
also had dementia. She just passed before it became really she was never diagnosed. We just began to notice she was having problems.
Right, right. So, you know, that goes back to like a lot of patients ask me, well, what is it exactly that I have, you know? And like I was trying to say earlier, we can never tell exactly what we have in front of us because we would do an MRI and we see these cholesterol plaques, right? So you think, okay, maybe it's a vascular dementia, but then you do an amyloid PET scan to look for beta amyloid, and that's also there. So what is it? Is it an Alzheimer's? Is it a vascular? Is it both? And so the point is that um, a lot of times it's best guess, right? And a lot of patients don't just have one thing. They can have Alzheimer's, but they can have a vascular because they had or have active issues of cholesterol, diabetes, blood pressure, whatever. And some people are genetically prone to getting cholesterol plaques in their brain, even if they control their risk factors with diet and exercise and meds. So, you know, just because you see plaques in the brain MRI, you can't really call it. It's an overall diagnosis. Like that's why I explain my patients. It's like not one test that tells me, the neurologist, what's in front of me. It's a process of different things. It's me asking the patient questions, me asking the family questions, me doing the testing, me doing the blood testing, me sending for MRI, me sending for amyloid PET scan, me doing EEG. And then you can really know if there's an issue. And of course, they have to show evidence of cognitive impairment, meaning memory issues, or by doing at least a screening test. Like I said, the mini mental status exam is one I do in the office, or the MOCA, the Montreal Cognitive Assessment exam. So I don't know if I answered the question. I apologize if I've digressed, but
And just to add to it, she's having a lot of dizziness and balance problems.
yeah, um, the dizziness balance problems depends on different factors and doesn't really tell me anything about the type of dementia. Dementia themselves, or like even Alzheimer's, is not supposed to cause dizziness per se. There's different things that could cause it. Again, if she has neuropathy from the diabetes, that can explain the dizziness. If she has inner ear problems, that can cause dizziness. Um, that's why we have people like myself, like neurologists, that can try to hopefully figure out what's going on. And sometimes a person can have multiple things on at the same time. Doesn't mean that it's just one thing that explains everything, you know?
Okay, thank you.
Sure, no problem.
Thank you. Madeline?
Oh, no, he answered my question.
Okay, great.
Thank you.
Is there another question in the room?
Yes.
Yes. Oh, wait, let me,
Oh, okay.
before you go
No,
second,
no.
again, let me go to Denise online.
Greetings, family. Can you hear me?
Yes.
I have a question about research. I know what you just stated in terms of leaning towards, going to try to get an assessment because you feel like you're not remembering things and you're forgetting things and you want to know. Um, does the research show? Because my belief, based on two individuals that have been diagnosed, would have done everything supposedly to prevent. And I just feel like it's no prevention, it's slowing it down. So my reason for doing research, and if that is encouraged, to do and have the research so you can start to slow it down. If and again, it's like, do I want to know? Don't I want to know? But
Right.
then we would steer away from research, and we need to research to try to see how we can come up with some sorts of, again, maybe slowing it down. If someone comes up with stopping it, I would be really grateful, but it seems like slowing it down is where we put the effort.
At this point, yeah, but I mean, of course, if more people would be willing to be involved in clinical trials, especially, that's one of the other issues that you guys may already know. You may know that, there's a lot of unrepresented ethnicities, and we do know that also African Americans, for example, have different rates of progression and different even these serum biomarkers may not be applicable as much for certain races. So it's very important that you guys or people in general, especially of different races, not just Caucasian, to try to be involved in clinical trials because they'll help everybody, not just one person or one race. So I do encourage people to, if they want to, of course. Yeah, and trials are they're not easy, and they do take time, especially these Alzheimer's type or these dementia type trials, right? Because they go for at least a year and a half or some amount of time that do involve a family member being involved, have to be involved, obviously, for different reasons, for logistics and asking questions and they may get even placebo at least. But the good news is that most trials nowadays do eventually get to be the people who are in placebo, for example, eventually do get to be pushed into the open label extension, meaning that everybody gets the drug, even the people who are in the getting the drug or people who didn't get the drug now do get the drug. And so I think it's a good thing to be involved in a clinical trial. And a lot of them also obviously compensate for your time and money and the effort to come in and depending where you come from. And they usually do reimburse your travel, or they should, or they offer other benefits. So I do encourage people to consider finding a clinical trial place to be involved if they want to.
And thank you. And I will say that ACTS is involved with a center that comes out and encourages us to be part of studies because again, a lot of studies aren't based on having looked at African Americans or how
Mhm.
people of color and different ethnicities relate to these diseases. The
Right.
other thing I wanted to say in terms of different things that are out in the community, I'm part of a team and we provide training um, for caregivers, specifically on behavior health,
That's
Opeka
great.
Day Center, and there's so many resources through Opeka, and I'll share that at the end.
Oh, great.
So thank you so
Yeah,
much
thank
for
you.
this information. It's
Sure.
invaluable.
Thank you. Thank you for
And good to
sharing
see
your
everybody.
information. Thank you.
You have another question?
Yeah, I have a question. Pat, what is the statistics based on just maybe what you've read on dementia in the United States as opposed to other countries like Europe
Mm.
or Africa? Do we have it more here? And if so, what do you think would be the reasons why it would be more prevalent in the United States versus other countries?
I think Western worlds in general are thought to be heavily more in having more Alzheimer's. I don't know the numbers, but it's ultimately thought to be linked to diet, right? More and more people are not or being exposed to a Western diet that's not necessarily a good diet, right? The things that we talked about that you should avoid, the high sugars, the high fats, high red meats, and bad food substances. So as far as exactly what the distribution is, I'm not sure. I'll have to do a little search myself and let you know. But also the thing to also sort of note is that possibly that certain continents or countries may not have the resources to do to have the diagnosis available for them. For example, maybe places like Africa may not be able to do those blood tests that we have here in the United States, or maybe they just not ha don't have access to healthcare as much as people here in the United States. So that's another thing to consider. So the numbers may not really be really reflective of what's really going on, unfortunately. So it may not really be a good answer regardless.
Thank you. Do we have any other questions?
I have one more.
Right.
You mentioned something about seizures. If a
Yes.
person develops seizures, I have a friend who is in her late 50s and she started having problems in the last probably 5, 6, 7 years and it went undiagnosed. And then recently she was just told she was having seizures. So I was a little concerned when you said that.
Okay. And she also has memory issues or dementia?
She
Oh,
worked with me for a minute and I noticed that her memory, when she had an episode, that her memory was kind of off a little bit,
uh-huh.
but it goes in and out. Now it's fine. She works, she's, full-time on a job,
Yeah.
but with her at one point, she did have some issues with her memory,
Mm,
for a short spell, but then again, it
mm.
seems to be fine. But I'm not with her every day. But
Yeah.
she's gone to the hospital 3 times in a matter of 3 months, and then they finally said, "Oh, she's having seizures," which I was
Uh,
surprised.
right. So epilepsy or seizures, or epilepsy is basically recurrent seizures of not provoked by anything external. So, just by having seizures, you are at risk for having brain damage if they've been ongoing for too long. It's because like when we say seizures beget seizures, and it's like think about it like a short circuit, and like you have this loop that's like just keeps acting out itself. And just by just having this short circuit happening, there's inflammation and basically more scarring and more death of cells, if you will, around that area. It's usually more on the rare side, to be honest with you, as far as seizures in general, right? Compared to other disorders out there, epilepsy is not as common. And people with dementias, for by and large, do not have seizures as well. But people who have a lot of seizures also don't have to have dementia. It could be that they're having the lapse of memory, if you will, because they're spacing out. And not every seizure has to be the whole body, tonic-clonic grand mal, right? There are other types of seizure where they're just staring or doing some weird things like lip smacking or, buttoning their or posturing their hand. So those could be all parts of a seizure. And just by having a seizure, you can have damage to the brain. But yeah, there's no, for the most part, just having dementia by itself doesn't mean that you are more likely to have a seizure. There are a few cases I've seen over the years of people more advanced Alzheimer's type dementia, and the theory is that you have enough scarring from all these plaques in the brain, and then just having these scars in the brain causes electrical wiring to be a little bit off. And that's what seizures are. Seizures are the firing of cells together in unison. Because a normal brain, if you look at it from a neuronal standpoint, every cell fires at a different rate, different frequency. But when you have a group of cells firing together, that's what a seizure is. And sometimes it just affects one part of your brain where you may be just staring or doing some weird thing with your hand, or sometimes it starts recruiting a whole bunch of cells, right? And that's when you get the whole body shaking, stiffening, the grand mal. That's what a generalized seizure is, or a tonic-clonic seizure, or grand mal. That's the name for it, basically.
Yeah. Linda?
Okay. My question is, I noticed my mom over the year, she has a habit of repeating herself
Mhm.
a lot. And I could be sitting there watching the same thing she watching on TV and she repeats it. My question is, we just found out she's had stage 4 lung cancer, right?
Mhm.
So she's doing infusion and all these other injection. My question is it necessary for her to be tested for dementia, Alzheimer's, considering what she's going through now?
Yeah, yeah. So, it's like I always kind of bring that up to my patients as well. It depends on when you do a test as a doctor, you want to do it in the purpose of deciding if it's going to make change, excuse me, change management or not. So in your mom's case, if they were to diagnose her with Alzheimer's, for example, by doing the blood test or amyloid PET scan, maybe it'll be nice to know that she has it, but is it going to change management? That's what you have
Okay,
to ask yourself, right? Because
right.
you could do the blood test, it's a blood test. You could do an amyloid PET scan if you wanted to, I guess, and even get more information. But what would that help you with? Because at the end of the day, nowadays, I think that the testing I'm talking about, the blood serum biomarkers, the PET scan, uh, are more beneficial for people in the early stages that don't have any other issues and can maybe undergo those infusions, or at least early enough in the disease stage where you can do other modification. And maybe your mom's case is a little bit tough because she has another problem. She won't be eligible for these infusions anyways, for the ones I'm talking about. And at the end of the day, the doctor could put her on the same medication that we used to put on patients with memory even before we had all these tests, right? The donepezil and the galantamines. So that's a good question. At the end of the day, I also always bring it up to the decision of the patient. And I basically caveat by saying, okay, we could do these tests, but you have to also realize that it may not change the management. Because
Yeah.
me as myself as a neurologist, I might say we could do these tests, but I'm just going to put her on that donepezil or that galantamine anyways, as long as the other doctors are okay with that drug, because to make sure that doesn't interact with anything else. So yeah,
Okay,
that's a good
all
question.
right. Because she has a lot of everything, diabetes and all that stuff. So she doesn't want to do much of anything. She just want to let God do whatever he wants to do. But I was just curious,
Yeah.
about it. So thank you for your time.
No, no, no problem. Yeah, these are all good questions. Thank you for very good questions. Thank you.
Uh, Dr. Benmoshe, this is Sharon, and thank you so very much. But with our mom and my sister, Jeannie's here. You met Jeannie in the office.
Yes.
Uh, we had decided if mother got any kind of other disease, we just gonna let her, we're Christians, we could go on home to the Lord, because mother had already told me, I can't stay here forever. So that's all I'm just saying. It has to come to that point. You're trying to hold on and keep it when they want to go. So actually, from my perspective, it's the loved one that's gonna be here that needs the help. Cause they got to know, okay, now I'm gonna have to get ready to let them go. And my own personal thinking of this disease, why it's so horrible, this Alzheimer's, is because by the time you finish caregiving, just be honest now, you ready for them to go.
Hmm.
It'll wear you out.
Yeah.
So that's my 2 cents.
Yeah, no, that's a good point. Because at the end of the day, yeah, like it's the quality. Sorry,
Yes.
sorry about that.
I hope you feel better.
We don't hear anything, Dr.
Okay.
You
It's
have a good voice counseling.
You're not feeling well.
We only hear you.
Oh, the dog. If she a dog lover, for something.
We don't hear anything but you. So your microphone is great. Yeah.
Anyways, what was I saying? Yeah, at the end of the day, yeah, it's like about the quality of life for the patient themselves, right? Do they really want to go through all this hassle of testing and being prodded and poked and going through the infusions that has their own side effects and all these kind of things? I mean, it's really the decision of the patient and hopefully the family members of kind of came together and come up with a overall plan. If this happens, this should be done, etc. That's what it is. It's all about quality of life, really.
Yeah, thank you. Thank you. I do think every situation is different, and I agree with what you said, Dr. Benmoshe. It really is up to the patient and their caregiver. We are faith-based here, so I would say definitely lift it up in prayer. But every situation is different.
Right.
So we keep that in mind.
And if I may, one other thing, when we gave mother that Aricept, she told me, she said, oh no, she said, I'll lose my memory before I have these headaches. So it's like what you're saying. After that, I said, okay, mom, shoot, I'm done with it.
Right. Well, certain medications like Aricept or donepezil, they're very much. I think that it's still worth trying on patients because if it's going to help them
Yeah,
have a better day-to-day experience and help the caregivers, you guys have a better day-to-day experience, and why not? And just because they may have failed one drug or maybe they couldn't tolerate one drug doesn't mean they can't try other drugs. Like as I mentioned,
yes.
even the Nepazil, I don't like to use that anymore because I feel like the other guys in the same class, the other drugs in the same class have less side effects. So you should always discuss with your neurologist about side effects and just make sure that they know that, okay, my mom or my dad tried it, they couldn't tolerate it. Can you maybe try something else? And there's always something else, I think. Again, these drugs again are not cures, but the idea is to help the patient and their caregivers have a better day-to-day experience, when they're not asking the same questions over and over again. And that's what these drugs are supposed to do, is to help with a short-term memory so they're not asking you, the caregiver, the same question over and over again. They can actually focus better, they can do more stuff, they can maybe more active in their social settings. That's what these drugs are supposed to do.
One other thing. Dr. Benmoshe sharing again, one other thing when, as you can see, I can talk, but anyway, when I called Alzheimer's Association
Uh-huh.
and talked to Dr. Brian Gaines, who partners with us, but he told me at the end of the conversation, he said, the best medicine is love and care.
Yeah, that's true. I agree. I agree.
Yeah, I just want to throw that out there.
Yeah, good point. Thank you. Good.
Dr. Benmoshe, we cannot thank you enough for joining us this morning.
Yes.
Thank you guys. Thanks for having me.
Your knowledge, we truly appreciate it. Do you mind putting your information in the chat? Do you have a website, phone number, address, for anyone who would like to possibly seek, your help.
Oh, sure, sure, no problem. I'll put it right now, actually. Give me one sec. Change the LA neurology. Yeah, that's it. I'll just put in my website right here. Uh, let's see, chat, right? In the chat. Okay.
Yes.
Okay. There you go. That's my website. They should have my phone number and all, and the you can even put a request on the website itself if you guys want to request for a consultation, and my staff will reach out to you guys, or you can just call.
Thank you. Thank
Sure.
you so much. We truly appreciate it. You're welcome to stay on, or if you need to drop to take care of that baby or take care of yourself.
Thanks. I appreciate it.
Totally understand. Thank you so
Okay,
much.
yeah, I'm gonna go, but thank you so much, guys. Thanks for having me. I appreciate it. Okay.
Thank you.
Take care, guys. Bye bye. Thanks for having me. Bye.